Welcome to the Deep Dive. We're here to streamline complex research, source materials, really, into the actionable insights you need.
That's right.
And today, wow, we are tackling a massive strategic shift. We're diving into, well, nothing less than the blueprint for fundamentally re-engineering U.S. healthcare delivery.
It's a huge topic. For decades, the system has struggled. We're talking systemic failures, unsafe care, spiraling costs.
Yeah.
So we're trying to move beyond that failing, frankly, mismanaged 20th century model
Towards something better.
towards one rooted in patient safety, quality, and crucially rigorous theoretical change management.
Okay, so our sources for this deep dive, they really detail this revolutionary approach.
Yeah.
The focus seems to be on the leadership provided by the Doctor of Nursing Practice, the DNP.
Exactly.
We're looking at the specific educational mandates, the shift toward genuine interprofessional collaboration,
It's just key.
and the sort of hard science, really, of implementing sustained system-wide improvements.
And our mission here, is to uncover the exact framework. The framework designed to transition U.S. healthcare toward what's known as the triple aim.
Ah, the triple aim, right.
And this isn't just tweaking one thing. It's about balancing three goals that have often been seen as, antagonistic.
Yeah, they pull against each other.
Enhancing the patient experience,
Yeah.
improving care quality for populations, and the big one, reducing per capita costs.
That focus on the triple aim is so important, isn't it? Because like you said, traditionally, you improve quality, costs go up. You cut costs, quality often takes a hit.
Right.
So the DNP model is trying to do all three simultaneously.
Precisely. It's incredibly ambitious. A huge mandate.
Okay.
And to really understand how we even got to this point, we have to look back to that moment when the system was basically forced to admit it was fundamentally broken.
Right, the tipping point. And that moment was really the turn of the millennium, wasn't it? Triggered by those powerful reports from the Institute of Medicine, the IOM.
Those reports were absolutely definitive. They forced this industry-wide self-examination.
And you know what I found really surprising reading through the material was the sheer public interest. That IOM Future of Nursing report in 2010,
Yeah.
apparently it had more internet hits than any other IOM report ever.
Wow. That's significant.
It really shows the public was, demanding systemic change, right? They knew things weren't working.
Absolutely. They felt it.
Okay, so let's start there. Let's unpack that mandate for change. Because this revolution, it wasn't driven by small problems, minor inefficiencies.
No.
The system was failing in, catastrophic ways. We're talking about those seminal IOM reports. To err is human.
From 2000.
Right, 2000. Which quantified that just tragic number of preventable deaths from system failures, and then crossing the quality chasm in 2001.
Those two reports, they just created this immediate ethical and professional crisis. You can't read them and not feel it.
No.
Their impact just catalyzed these immediate, crucial shifts
Right?
right across the healthcare ecosystem.
Like what specifically?
Well, overnight, patient safety research became this massive area of study, improvement science too, clinical translational science, and the mandate for widespread adoption of evidence-based practice, EBP.
Right, EBP.
This work, between roughly 2000 and 2005, was absolutely foundational to developing the DNP degree itself.
It sounds like the industry realized the failure wasn't just about, individual clinical mistakes.
No, it was deeper.
It was rooted in complex communication failures, how professionals were trained, or maybe not trained together.
Exactly. Which brings us to that third crucial IOM report in the sequence, Health Professions Education, A Bridge to Quality. That was 2003.
Now, what's fascinating there, as the research notes, is that this education report, it didn't get the same media frenzy, did it?
No, it didn't. The research suggests, and it sounds cynical, but probably true, that education reform is just not as sensational as lost lives.
Sad but true.
But the report pushed back hard. It argued that flawed education is, in fact, losing lives once removed.
Once removed, that's a powerful way to put it.
Because poor collaboration, fragmented training, that directly results in those preventable errors and the added costs everyone was talking about from the earlier reports.
So education, specifically the lack of interprofessional integration, that's presented as the root cause problem here.
Absolutely. Yeah. And the IOM's multidisciplinary team, they suggested 5 core competencies, things that needed to be woven into the curriculum of all healthcare education programs.
Not just nursing, not just medicine.
No. Medicine, nursing, pharmacy, dentistry, you name it, across the board. These weren't just nice ideas, they were structural demands.
Okay, what were they, these 5 competencies?
They became the bedrock, really. First, the ability to provide genuinely patient-centered care.
Okay.
Second, the ability to work effectively in interdisciplinary teams.
The collaboration piece.
Yes. Third, the capability to employ evidence-based practice, EBP. Fourth, the skill to apply quality improvement, or QI, methods.
QI.
And finally, fifth, the essential function of using informatics, leveraging data technology.
Those 5 seem clear.
Hmm.
But if you look at let's say, the political reality of changing curricula in these very established, siloed professional schools, which of those 5 do you think was the biggest hurdle, the hardest sell?
Oh, undoubtedly the second and fourth. Working in interdisciplinary teams and applying quality improvement.
Why those 2?
Well, think about it. Medicine schools, nursing schools.
Mm-hmm.
Historically, they focus on deep clinical knowledge, right? Individual expertise.
Sure.
But systems thinking, QI, the ability to run data cycles, refine processes, that's often seen as, I don't know, an administrative function.
Yeah.
Or maybe engineering, not core clinical work.
Not what doctors do or what nurses do.
Exactly. And team-based work. That inherently demands that professions give up some autonomy, shared decision-making. That's always politically charged within academic silos. Oh.
Okay, that makes sense. And then nursing specifically got this definitive call to action in 2010. The future of nursing.
Yeah.
Leading change, advancing health.
Yes. A landmark report.
And this report really cemented the need for the DNP, didn't it? By issuing these specific, almost non-negotiable recommendations that seemed to demand a higher level of preparation.
Absolutely. Higher than the traditional master's degree offered. The recommendations were pretty comprehensive.
Like what?
First, nurses must be able to practice to the full extent of their education and training, which really meant pushing hard to remove practice barriers for advanced practice nurses, APNs.
Okay, scope of practice issues.
Big time. Second, nurses must achieve higher levels of education and training. That recommendation gave enormous political weight to the DNP transition.
Ah, so it directly supported the DNP movement.
Directly. Third, and this is critical, nurses must be full partners with physicians and others in redesigning U.S. healthcare. Not assistants, partners.
Full partners, okay.
And finally, there was a really pragmatic demand for better data collection. Improved information infrastructure. You need good data for workforce planning, for policymaking.
Right. So that sets the stage. But why the DNP specifically? Why couldn't a, revamped or specialized master's program handle this kind of systems overhaul?
That's a great question. The DNP was developed precisely because the scale of the problem system, complexity, spiraling costs, the explosion of technology, it was just seen as far beyond traditional clinical expertise, even at the master's level.
So it needed something more.
It needed a different kind of preparation. The DNP was explicitly developed to, and this is a quote from Novak back in 2006, re-engineer healthcare. Not just manage it better, re-engineer it.
Re-engineer, that's a strong word.
It is. And it requires a level of leadership development, systems analysis, translational research skill that's really only delivered at the doctoral level.
So what are those core capabilities a DNP student brings?
They're trained in things like health promotion, disease prevention, patient safety, quality improvement, but always within a population systems context.
Systems context.
And often through the lens of social justice. They're meant to be the systems architects of this new healthcare model, you see. Not just expert practitioners working within the old, broken one.
Okay, so moving from the why, the educational mandate, to the how do DNPs actually operate and sustain these new collaborative environments? The sources focus a lot on nurse-led clinics. They call them learning collaboratories.
Yeah, these clinics are designed as these integrated spaces, right? For DNP students, for interprofessional education, IPE for practice, for research.
All in one place?
All in one place.
Mm-hmm.
They're community settings where students partner up to design systems that address the specific needs of where people actually live their lives, where children, families, adults learn, live, work, play, pray.
Sounds ideal. But the research you mentioned on past efforts, sounds a bit sobering.
It is sobering. Historically, many attempts at academic nursing centers, they failed. Lasted maybe 1 to 3 years.
Why? What was the weak link?
Fatal dependence almost always was on a single grant for funding.
Ah, the grant cycle dependency.
Exactly. That lack of sustainability just undermined 50 years of really excellent, innovative efforts.
Yeah.
Quite tragic when you look back.
Wait a minute. If decades of these efforts failed because they relied on single grants, doesn't that suggest the system itself is resistant to this kind of innovation? Regardless of DNP training, how do they break that cycle, that dependency culture?
That is the critical question. And the answer, according to the sources, lies in this integrated model of sustainability. They call it the Mosaic of Support.
The Mosaic of Support. Okay.
This is presented as the crucial blueprint, the way to ensure long-term replicable success for these nurse-managed health home models. DNP students must learn this model of longevity. It's built not on one fragile stream, but on diversified resources and really strong collaborative partnerships.
Okay, walk us through the pieces of this mosaic, figure 17.1 in the material, right? What are the practical pillars DNT leaders need to build and master?
Well, the foundation is, perhaps surprisingly simple but often overlooked, effective, thoughtful, positive communication.
Communication first.
It underpins everything. Collaborative tier relationships. Without that strong relational core, the rest just crumbles. Doesn't matter how good the plan is.
Makes sense.
Then, from a more structural perspective, the DNP leader absolutely has to develop and maintain a clear value-based business plan or a faculty practice plan.
A business plan for a clinic.
Yes. This plan has to demonstrate how the nurse-led clinic delivers care that meets that triple aim we talked about. Superior quality, better patient experience. Often, and this is key, at maybe 1/3 the cost of traditional medical models. You have to prove the value proposition.
Okay, prove the value. And financially, you said diversification is key. How do they actually move beyond just chasing the next grant?
They need a broad portfolio, a mix of financial resources,
Such as?
aggressively pursuing revenue from Medicare and Medicaid billing, maximizing patient revenues from private insurance. And then, alongside that, securing grants, federal, state, foundation, plus private donors, local fundraisers. It's a whole ecosystem.
Wow, that's a lot to manage.
It is. The goal is complete financial independence and replicability. The Mosaic model insists that relying on any single stream leaves the whole system vulnerable, fragile. So DNPs are trained not just as clinicians, but really as CEO-level business architects. They have to manage this complex financial picture.
Now, one really interesting element here, seems quite forward-thinking, is this idea of connecting with non-health disciplines. The sources stress thinking beyond the usual health science collaborators. Who are we talking about?
Yeah, this is exciting. We're talking about leveraging just the tremendous synergistic potential you get when you meld DNP students with students and faculty from, say, industrial engineering.
Industrial engineering.
Or biomedical mechanical engineering. This moves collaboration way past the typical health science silo. It integrates engineering principles directly into how DNPs develop curriculum and design clinical processes.
That sounds like a really powerful cross-pollination. What specific expertise do engineers bring to the healthcare table that a DNP leader needs to leverage for this kind of systemic change?
Well, engineers bring these core competencies in systems thinking that are just essential for tackling the complexity crisis in healthcare. They bring expertise in root cause analysis.
Finding the real problem.
Exactly. Identifying those deep, non-obvious failures. Systems design, which lets you create robust, maybe even error-proof processes. Device design, obviously. Simulation modeling. And maybe most critically, human factors.
Human factors.
Understanding how humans actually interact with technology and processes. How do you design things to minimize the chance of error? It's human factors.
So a DNP leader could partner with, say, a mechanical engineer, not just to build a better widget, a better medical device,
Right.
but to redesign the entire flow of an ICU using principles like Six Sigma from manufacturing.
Exactly that. You're applying the kind of precision thinking used in aircraft safety or high-stakes manufacturing directly to patient care pathways.
That's a paradigm shift.
It really is. And this melding of different fields, it creates this dynamic, innovative environment. The sources call it a horizontally and vertically integrated interprofessional learning environment.
And who benefits?
Everyone. Students develop these highly practical, cross-functional skills. Faculty across nursing, health science, engineering. They learn from each other. They create new educational models, new practice models together.
Yeah.
It's a win-win-win.
Okay, this whole shift towards collaboration, it's clearly central. But it brings us to a really crucial theoretical distinction that one of our sources, Reflective Response 1 by Charles, highlights. We hear interprofessional and interdisciplinary used almost interchangeably all the time.
All the time. And the research argues that difference is absolutely essential if we want true system reform.
Okay, let's clarify this because it seems important for DNP leaders.
It's critical if they want to move beyond just, talking about collaboration.
Yeah.
So let's break it down. Interdisciplinary practice, or ID, that focuses on using the specialized knowledge from two or more professions. Let's say a nurse-managed clinic uses knowledge from audiology and dentistry to treat a patient. They're coordinating their expertise. The goal there is the best service delivery. You're essentially coordinating different toolkits.
So ID is like a team using their separate specialties, working side by side to fix a specific problem.
Precisely. Now, interprofessional education, or IPE, that's different. It's a structural concept designed to create a much deeper change. It's when two or more professions purposefully interact to learn with, from, and about each other.
With, from, and about.
Okay. The goal of ITE isn't primarily about immediate service delivery. It's entirely focused on achieving a shift in mindset, learning to see the world through the perspective of the other profession.
Ah, okay.
Working in the same room is ID, actively trying to restructure how you think based on what the other profession values and how they see the problem. That's IPD.
That sounds necessary, but incredibly difficult. A huge hurdle. I mean, if everyone ultimately shares the goal of patient wellness, why is it so hard to stop seeing the world only through your own professional lens?
Well, the core issue, as the sources really emphasize, is the development of professional identity.
Professional identity?
Yeah, this identity, it's largely formed during our entry-level training, right? Nursing school, medical school, law school, whatever it is. When students spend years training almost exclusively with their own kind, interacting primarily with their own profession, they deeply internalize its specific values, its attitudes, its knowledge base. Think of it like a military academy. That rigorous insular training creates absolute loyalty to the platoon's worldview.
Right. So the very specialization that makes them experts also builds the walls, creates the barrier.
Exactly. They start to see the world almost exclusively from the viewpoint of their profession. And often, consciously or not, they assume their way is the correct way, the only valid way to approach a problem.
Right.
This lack of systematic exposure to other professions during that crucial developmental period, it means individuals develop what the sources call insular behaviors.
Insular behaviors.
They fail to systematically expose themselves to, or really accept, other valid worldviews. And this narrowing of perspective, this is what creates the turf wars, the communication breakdowns, the misunderstandings, and frankly, the pervasive personal conflicts we see in high-stress clinical environments.
Wow. That's a fundamental challenge, isn't it? To ego, to specialized training, to how we think of expertise. So, if professional identity is the barrier, how do DNP leaders, whose whole mandate is collaboration, how do they effectively break down that insularity?
They have to focus on a concept called mattering.
Mattering.
Mattering. The research highlights this as key. Mattering is the active relational process of expressing that we understand and accept the members of other professions, and crucially, that their knowledge, their skills, their worldviews are essential and important to us.
So it's not enough to just tolerate the audiologist down the hall.
No.
You have to actively validate the unique and indispensable nature of their contribution to the team, to the patient.
Yes. Our sources stress that feeling that we matter to others is absolutely key in decreasing interprofessional conflicts, turf battles, territorial disputes.
Okay.
In the absence of that sense of mattering, there's a really high likelihood that conflict arises not from genuine clinical disagreement, but from status issues, from ego insecurity. And the sources are blunt. Until nurses and other professionals address their own role in creating and maintaining these boundaries, these silos, until they're willing to challenge their own professional worldview and the rigid definition of their turf. Change will only be about how we talk about collaboration.
Not how we actually practice it.
Exactly. True IPE requires being willing to invite others into areas of practice traditionally claimed as one's own.
Yeah.
To actively demonstrate that their perspective matters, not just in general, but to your professional core. That's the hard work.
This discussion about these deeply entrenched behaviors, these professional silos, it leads us right into the need for implementing large-scale system change using a really rigorous theoretical framework. Because, as you said, the failure rate is just devastating.
It's shocking. 2/3 or more of organizational change projects, they fail outright.
2/3.
So an unstructured approach, just kind of hoping for the best, it's basically a guarantee of failure in complex systems like healthcare.
So you need a map.
You need a map. That's why DNP leaders, equipped with this comprehensive leadership training, rely on established change theory. Planned change isn't accidental. It's defined as a purposeful, calculated, collaborative effort to bring about improvements, usually with the assistance of a designated change agent. You cannot rely on hope or just good intentions here.
Okay, let's start with the foundations then. Kurt Lewin's work from way back in 1951, he outlined 3 mandatory stages, right? Stages change agents have to go through.
Lewin's model is the simplest, most foundational structure. It's the starting point. Stage 1 is unfreezing.
Unfreeze.
This is the critical stage. The change agent assesses that change is needed and then deliberately introduces disequilibrium into the system. You have to shake people out of their complacency, show them why the status quo is actually more painful, more risky than the effort required to change.
Create the motivation.
Exactly. Stage 2 is moving. This is when the change is actively initiated. The change agent gathers information, solves problems as they arise, develops the detailed plan for the transition.
Okay.
And stage 3 is refreezing. This is where equilibrium gets reestablished, but at the new desired level. The change agent works really hard here to make the changes permanent. Lock them into new policies, new training routines, embed them in the culture so the system doesn't just drift back to the old failed practices.
Prevent regression. Okay, unfreeze, move, refreeze. Seems logical. But the research suggests Lowen's model gets criticized, right, for being maybe too simple for really complex hospital systems, maybe ignoring organizational politics.
It does get that criticism, which brings us to a more detailed, more practical framework. Lippett's 7 phases.
Lippett's 7 phases.
Yeah, this theory is highly valued by DNP leaders, apparently because it aligns so closely with the nursing process that they're already familiar with. You know, assessment, planning, implementation, evaluation.
Okay. It fits their existing mental model.
Precisely. It offers the specific, incremental steps needed for these really large-scale projects.
Okay, walk us through some of those key phases. What does Lippett add?
Well, the first 2 phases really cover the detailed assessment and planning needed to overcome that initial inertia. Phase 1 is diagnosing the problem, and this goes beyond just surface issues.
Deeper dive.
Exactly.
Here.
It requires a comprehensive literature review you need to bolster your position with irrefutable evidence. It involves initiating a formal project management framework and developing a detailed draft guideline of the proposed change. But crucially, that draft guideline should be given to everyone likely to be affected, but explicitly left open to their input and initiative.
Okay, so diagnose, research, propose, but invite feedback.
Yes. Yeah. Which feeds directly into phase 2. Assess motivation and capacity for change. This is where the human element, the resistance, has to be actively managed.
The sticking point.
Absolutely. This is the crucial stage for transparent communication. Responding to every single concern, providing the clear, ethical, and practical justification for why this change is necessary now. You have to address resistance head-on, which leads us to the tool Lewin actually developed for exactly this task. Force field analysis.
Right, force field analysis. I've heard of this. It sounds like an indispensable tool for navigating complex problems. How does a DNP leader actually use this framework to manage resistance in, say, a busy clinical setting?
It's a really elegant way to visualize the situation. It illustrates the 2 opposing sets of forces that are always operating during any potential change. On one side, you have the driving forces.
Pushing for change.
Right. These are the facilitators, the things advancing the system toward the desired change. Things like maybe better pay, opportunities for promotion, access to better training, public recognition of effort. And on the other side, you have the restraining forces. These are the barriers, the things impeding change. Things like fear of new technology, maybe fatalism based on previous failed change attempts, lack of required skills or competence, or just simple staff inertia. Resistance to doing things differently.
So the core strategic insight here isn't necessarily trying to do the impossible, like eliminating every single barrier or fear.
Correct. That's often unrealistic. The analysis assumes that many restraining forces are deeply embedded psychological realities, cultural norms they often can't be entirely removed. So the strategy, therefore, is to counter them. Systematically identify and then increase the driving forces until the balance of power shifts decisively in favor of the change.
Can you give us a concrete example of how that might play out?
Sure. Let's imagine a DNP leader trying to implement a complex new electronic health record system in EHR, a huge change.
Okay, common scenario.
A strong restraining force might be: nurses genuinely believe this new EHR will significantly increase their documentation time, taking them away from direct patient care. You can't just dismiss that belief, right? It's a real fear.
No, you have to address it.
So the DNP leader using force field analysis must work to increase the driving forces. They might offer intensive personalized training critically during paid work hours, provide extra temporary support staff during and immediately after the launch phase, offer very visible recognition like super user badges or awards to those nurses who master and adopt this system quickly and help their peers. You're countering the fear of lost patient time with tangible increases in competence, support, and positive recognition.
That approach really requires a highly collaborative leadership style, doesn't it? You can't just mandate that.
Absolutely. And our sources emphasize that the change agent's leadership style is vital for success.
What styles work best?
Well, autocratic leadership, command and control, it's fast. It can be useful in an immediate crisis situation, like a fire. But for implementing planned systemic change that needs buy-in, democratic leadership is overwhelmingly more appropriate.
Why democratic?
Because it promotes cooperation, coordination, shared decision-making, and crucially, it builds that buy-in. That sense of ownership is what ensures the change actually sticks, that it survives beyond the initial push.
Okay. And finally, what about the overall strategies for actually implementing the change? Bennis and colleagues define some key approaches.
Yes, they identified 3 main strategies that change agents tend to use, often in combination. First is the empirical rational strategy.
Okay.
This assumes people are rational beings. They'll change if the plan is clearly justified by data and evidence, and if it's shown to be in their own self-interest. Appeal to logic.
Makes sense.
Second is power coercive. This is the classic top-down approach. It relies on authority, obedience, often involving some form of organizational reward or, frankly, threat. Do it because I said so.
The stick approach.
Pretty much. And third is normative re-educative. This strategy uses information, education, persuasion, and appeals to social norms to change underlying attitudes and behavior patterns, win hearts and minds.
Okay, 3 different levers.
And the research is pretty clear. The most successful, most sustainable change projects usually utilize a skillful combination of all 3. You blend the data justification with necessary organizational mandates and robust educational support. It's really just one approach.
Okay, so with that theoretical blueprint for change laid out, let's pivot to the concrete impact DNPs are actually having, particularly in areas like translational research and policy. One of the biggest frustrations in modern medicine, you hear it all the time, is that huge lag time between a scientific discovery and it actually getting into practice.
Oh, it's an almost unbelievable statistic, isn't it? Scientific findings can take, on average, up to 17 years to become standard clinical practice.
17 years.
That's nearly 2 decades where patients are potentially missing out on more effective care that we technically already know about.
That's unacceptable.
It feels unacceptable. And the DNP program, with its rigorous emphasis on interdisciplinary, relevant, evidence-based projects, it's specifically designed to attack that lag time, to significantly reduce it.
How do they do that?
By training leaders who can translate bench research, what's discovered in the lab, and then apply improvement science methodologies to get it implemented directly into the community or the clinical setting much faster. They bridge the gap.
This translational ability, does it extend into health policy as well? Because policy seems like another huge lever for change.
Absolutely. Policy change is explicitly listed as a key function of the DNP. Their influence is meant to extend far beyond the walls of just the clinic or the hospital.
Okay.
They're expected to engage actively in health policy design, implementation, evaluation at local, state, even national levels. And we have a really potent example in the area of cardiovascular prevention.
Heart disease, still the leading cause of death, right?
Yeah. Still number 1. Yet the sources highlight this striking fact. 60% of patients who develop coronary artery disease, CAD, have 0 or only one of the traditional risk factors we always talk about: smoking, high cholesterol, etc.
60% have few or no traditional risk factors. That dramatically shifts the focus, doesn't it?
Completely. It means we absolutely must shift from just reacting to symptoms to being proactive, focusing on personalized risk assessment.
How?
Specifically by looking for subclinical atherosclerosis. That's the presence of the disease before any clinical symptoms appear.
Finding it early.
Finding it super early.
Yeah.
And we can measure this non-invasively now using things like CT scans to look for coronary artery calcification. The technology exists.
Okay, so we can find it early. What's the policy challenge?
The enormous policy challenge is that these highly predictive tests, while powerful, are often not covered by insurance, private or governmental.
Why?
Because traditional insurance models are built around treating symptoms and diseases once they appear, not necessarily investing heavily in predicting future disease in seemingly healthy people.
So DNP leaders have to advocate for covering these kinds of preventative measures that the existing insurance models resist.
Exactly. They have to make the case, the clinical case, the economic case.
Did this advocacy actually translate into law anywhere? Is there an example?
Yes, the sources provide a really clear one. The Texas Heart Attack Prevention Bill from 2009.
Okay, Texas 2009. What did it do?
This bill, championed by health professionals, including nurses active in policy, mandated that insurance companies in Texas had to cover the costs of these CAD screening tests for certain at-risk populations.
They forced the coverage.
They did. And this wasn't just doctors giving clinical advice. This was policy change. Professionals using their expertise to overcome payment barriers, shifting the state's public health strategy from just treatment towards true prevention. That is the DNP role in action, leading system change through policy.
That's a powerful example. Now, beyond domestic policy, the outline mentions DNPs are also leaders in the, quote, local to global health policy arena. What does that involve? Understanding WHO, PAO, UNICEF.
It does. It requires a broader perspective, understanding how global health agencies work, how international health challenges connect to local realities. And the sources give a great example of what global DNP service leadership looks like in practice.
Where?
There's an ongoing interprofessional service learning project described in Cape Town, South Africa. It's supported by partners like Christelle House International.
What do they do there?
Teams of nursing students, medical students, other health science students work collaboratively, side by side with local community leaders. They provide school health programs, family health promotion, prevention efforts, interventions for major public health challenges there like HIV/AIDS, TB, malaria.
Wow, that sounds like an incredible opportunity for students to really break down those professional silos we talked about earlier. Nothing like shared purpose in a high-stakes environment.
Absolutely. And the impact reported is profound. It's measurable. After participating in these kinds of service learning projects, nearly half, 50% of the 98 health science participants reported changing their professional goals.
To what?
To focus specifically on public health in global settings.
Yeah.
It fundamentally shifted their perspective.
That's amazing.
And the core lesson reinforced again and again in these experiences is critical for sustainability. The community must lead the process. The sources call it the dance.
The dance.
Meaning the relationship has to be egalitarian, mutually respectful. It has to be built on local knowledge and priorities, not hierarchical or imposed by the visiting experts from outside. The community leads. The partners support. That's the only way it lasts.
This brings us right back, full circle almost, to that core directive from the Future of Nursing report and the campaign for action that followed it. Nurses must step up, be leaders, serve as a powerful voice for the community, bring others to the table. The passive observer days are over.
Absolutely. The need is urgent. The voice needs to be assertive.
Yeah.
There's a really powerful quote in our source material that just perfectly encapsulates this required shift in mindset.
What is it?
We must make sure that we are not just knocking at the door and hoping someone will open the door. We need to knock the door down.
Knock the door down. Wow, that's not subtle.
It's not subtle. It reflects the urgency and the need for nurses to claim their seat at the table where decisions are made.
And that level of assertive leadership, it's being backed up by real organizational action now, isn't it? Like the Nurses on Boards Coalition.
Precisely. 20 major nursing organizations formed that coalition. Their goal was incredibly ambitious. Put 10,000 nurses on governing boards across the country by the year 2020.
10,000 nurses on boards. Why is that so important?
Because nurses are consistently ranked as the most trusted healthcare profession. They bring a unique, patient-centered, systems-level perspective. They need to be physically present at the tables where policy decisions, strategic directions, things that affect millions of lives and billions of dollars are actually made. Their voice can't be absent.
And the pathways to that kind of leadership, they're varied, right? It doesn't have to be a hospital board right away.
Not at all. It starts often with workplace committees that extends to the PTA, neighborhood associations, community groups, eventually corporate boards. The sources remind us that often leadership just starts with a simple act of just showing up consistently, being present, being engaged.
Just show up.
But the key takeaway here is that DNP leaders, in particular, must be just as dedicated, just as passionate about shaping policy and leading in the community as they are about providing expert clinical care. It's two sides of the same coin for system transformation.
Well, this has been an incredibly detailed deep dive. It's clear the revolution, this re-engineering of healthcare, it really hinges on two things working together. That collaborative training, the interprofessional education piece, and a rigorous theoretical approach to actually managing system-level change, championed by the DNP leader using frameworks like lipids.
That's right. The failure to dismantle those professional silos, the failure to embrace planned evidence-based change. It literally costs lives and wastes billions of dollars. The DNP is positioned as the leader prepared to bridge that infamous 17-year gap between evidence and practice.
And if we connect all this back to the bigger picture, the source material really suggests that implementing something like lipids phases effectively, it requires personal change in the leader, right alongside the system change.
Absolutely. You can't effectively command or lead collaboration if you yourself are unwilling to challenge your own deeply ingrained professional identity, your own way of seeing the world.
So, reflecting on everything we've discussed, what's the final thought for you, our listener, now that you have this blueprint for system overhaul?
I think it comes back to that idea of professional identity. If the core barriers to collaboration really are rooted in that identity, in a resistance to letting go of those insular behaviors formed during your own training, that maybe unconscious belief that your profession holds the one true worldview, then the provocative question is this. What internal beliefs or practices, what parts of your own professional identity do you need to challenge or maybe even unfreeze to truly embrace an egalitarian, mutually respectful partnership in practice? Because real sustainable system change, it always begins with the personal change of the leader.